Welcome back, everyone. Let us now move on to the next session of the day. Note, it is not a session about your MySjatra app. It is entitled The Future of Digital Health. Join me in welcoming back Gopi Ganesalingam, Vice President, Tech Ecosystems and Globalisation, Malaysia Digital Economy Corporation, MDEC, as he discusses on the future of digital health with our esteemed panel speakers. This I pass over to you, Gopi.
Thank you, Hasro, and good morning once again, ladies and gentlemen, and welcome to the second panel for the final day of the Disruptive Week. This morning, we will embark on a topic that is so close to our hearts, healthcare. And we're going to discuss this in a very casual manner, no holds barred, and we've got an extremely nice lineup of panelists to share their insights. But let me set the stage. The COVID-19 pandemic has propelled digital health, where healthcare providers seek to leverage technologies such as telemedicine and other digital tools to continue to serve patients and to help combat the crisis. Globally, digitization of medicine and technological adoption has been accelerated, where innovation in big data and IoT are reshaping how healthcare is accessed and provided. In this session, our panel will discuss on how digital health are reshaping their business, tapping into why a hyper-connected healthcare is absolutely necessary and the support needed to achieve this. We have a very distinguished panel of experts, ranging from organizations that support innovation investments in health tech, a view from private hospitals, an entrepreneur who is reshaping and bringing insights to healthcare, and a perspective from a global insurance company on how health tech will reshape the insurance industry. Please allow me to introduce our panelists, and I'm going to do this one by one. And for each panelist to spend 5 minutes giving us an overview of themselves and the organization they represent. Let's go, ladies first. Bronwyn from Australia, all the way from Australia. Bronwyn brings with her over 20 years of experience in venture capital and accelerator background, specifically in healthcare. Bronwyn is the founder of ANDHealth, an Australian organization dedicated to supporting digital health tech companies in their commercialization journey. Welcome, Bronwyn.
Thank you, Gopi, and it's such a privilege to be here with you all today. I did spend 6 months living in Malaysia in my early 20s. It's a place that I hold very close to my heart, and I'm looking forward to a day where I could do this in person with you once again. I'm going to talk just very briefly about ANDHealth and what we do and the kinds of things we see in Australia and the potential that we see of health technology. And Gopi, to your notes, I will touch on some of the other infrastructure aspects that are happening in the background that we look to leverage as we grow Australia's digital health sector. So ANDHealth is Australia's only organisation which designs and delivers technology identification, screening and commercialisation programs. So we go out looking for the best and brightest and those with just great ideas, and we provide programs that help companies take those from idea to significant exit. So we have a very collaborative and cooperative commercialisation model. We have a number of global partnerships. We're the only team in Australia that only does digital health commercialisation. It's all we do. We live it, we breathe it. It's all we do. And unlike many accelerator models, we don't take any equity, and we're a non-profit organisation. In terms of how we see digital health, and Gopi, you did ask me to talk about the lower tier of this, and I will do my best, but it's not necessarily my area. But we do look at digital health as a category that encompasses what used to be called e-health or health IT at the bottom of that pyramid, which is, really system-wide infrastructure. It really powers a connected healthcare system. And without that, it's very hard to build higher value-add products. Where ANDHealth tends to work and spend the majority of its time, and 80% of its companies would be in the digital medicine and digital therapeutics spaces. So these are pieces of software or connected devices that attract medical device caliber regulation. So they're actually using technology to try to intervene into the course of somebody's chronic condition or acute condition in a direct way. So it has a higher level of risk from development, but it also has a potentially higher enterprise value at the end of it. It's a cooperative commercialisation model. So as I said, so it's very unusual. We work with our members in the top left bank, and they work closely with us to deliver our programs. So any company engaging with us gets a multi-sectoral view from all around healthcare. And to the points of that my colleagues will go into, this is an incredibly complicated and diverse sector that touches on many different sectors. It touches on insurance, it touches on policy, it touches on regulation, touches on pharma, multinational medtech, biotech, clinical trials. So we really need to make sure that when we're working with companies, we're getting all of those views. So our members include groups which represent all of the public hospitals in Australia, some of our biggest medtech manufacturers, global pharmaceutical companies, universities and centres of medical research excellence. We work closely with a number of international partners, and then we work across Australia very collaboratively. We really aim to never compete when we can collaborate. So in terms of just very simply, we do commercialisation programs, we have an event series, we collect industry data, we have a database of over 450 digital health companies in Australia, which we have met with, so it's not a survey, it's companies we work with, and we provide quite a lot of advocacy. So as per my colleagues on this call, it's really important to have people who are willing to champion the evolution of healthcare because it's an incredibly risk-averse sector. We've had a number of chats about the My Health record and the system connectivity piece within Australia. So at the infrastructure end, we do have the Australian Digital Health Agency. They receive about $250+ million a year. They are responsible for building and maintaining the My Health record, the e-prescribing system, which was accelerated in its rollout during COVID, and also our system connectivity and workforce education. We also have an amazing program in Australia called the Cooperative Research Centres Program. We have a digital health CRC. They really work to translate that science into the company formation part. So they really look to generate long-term economic impact by taking research through the earlier stages of commercialisation into company formation. We jump in after that and say, right, let's go take these companies global. So that's the area where ANDHealth plays. So I'm doing my best to roll in the more infrastructure elements of the Australian industry. We do it through a series of programs, not going into too much detail, but the core of these programs is recognising that in the chevrons across the top, the commercialisation pathway for digital health companies and the value points at which investors look to base their investments are very different than they are for traditional devices and pharmaceutical products. And so that really drives everything that we do at ANDHealth, is understanding the path to commercialisation, which is actually the path to scalable impact on patients for these companies, and how do we accelerate that? In terms of, we've been very successful. Our late stage program, it's called ANDHealth Plus. We were very grateful to receive almost $20 million in funding to scale this program over the next 4 years from the Australian government just last week. But with a very small bootstrapped pilot, we worked with 10 companies in the pilot program. And those companies have actually gone on to raise, I can now say, because somebody announced a raise last night, $71 million in less than 4 years. They've generated over $28 million in revenue. And most importantly, through commercialisation, they've impacted over 200,000 patients. This is the kind of funding we do. So we've got about $23 million in funding, plus another $6 million of industry contributions heading into this sector over the next 5 years. It's really important because when we talk about digital health in Australia, the median amount of capital that they raise is around $250,000. If that was a device company, that would probably be 10 times that. And if it was a pharmaceutical company, it could be 10 times that again, or a biotech. So we really need to be conscious of the fact that in Australia, our investment into this space is still very nascent. We're not seeing the volumes of deals that we've seen before. But what we are seeing is an opportunity to leverage our traditional strengths in great healthcare, pharmaceutical and biopharmaceutical development, medical device development, and now into digital health development. We've got an opportunity to leverage our relatively COVID-safe environment as we start to open up again. We've got an advanced clinical trials capability. We work closely with international partners all across the world, and I thank Austrade for their role in putting me forward for this speaking engagement today. Our companies are bluntly cheaper than American companies for investors, so we do have what I like to call the valuation advantage. We have some fantastic tax incentives, and we have great health and medical research infrastructure and researchers. So these are all things that will enable Australia to build another tier to its medical technology and health technology industry, which is the digital health pillar. And, you know, really excited to work with Malaysia, because I think the Southeast Asian nations and specifically Malaysia and also Singapore offer immense opportunity for Australian collaboration. So delighted to be here, and I'm really looking forward to hearing from the rest of the panel. Thank you.
Thank you, Bronwyn. We are excited too. I think you'll bring a lot of insights to the panel. Next, we have Ben Ng, the CEO of AIA Insurance Malaysia. AIA is a brand that almost every Malaysian will know. So Ben brings with him 24 years of experience and is an actuary. Ben is a fellow of the Society of Actuaries and a fellow of Casualty Actuarial Society. Ben and his team in AIA are spending lots of resources in healthcare. So let's hear it from him. Ben, over to you.
Thanks, Gopi. Yeah. Hi, good morning. Good morning, everyone. Thanks for having me. Pleasure to be here. Yeah, just some quick introduction on AIA Malaysia. Yeah, next slide. Yeah, we're very proud to serve 4 million Malaysians here today. Yeah, their life insurance, health insurance, general insurance, as well as their retirement needs. As life insurance is a long-term contract, we believe that what's most important is to provide a professional advisor to give the customer the right advice and to be there long-term to look after the customer. So we're very proud to be the #1 MDRT in Malaysia for 6 consecutive years. In fact, AI in Malaysia alone ranked top 22 globally. So MDRT is an international recognition for excellence. And we're also very proud to have great partners like Public Bank and Touch and Go Digital. Recently, we're very honored to be ranked #4 in the top companies to work for in LinkedIn, the only private company in the top 5. So as we know, insurance is a good source of long-term funding. AI today manages about 60 billion ringgit, 15 billion US of asset here. And we're also the #1 group insurance provider in Malaysia. Next. In AIA, our purpose is to help people to live a healthier, longer, better lives. We want to move away from a traditional role of an insurer where we just collect premium and pay the claims. We want to be an active partner. We want to be there for our customer, not one day, not just in case, but every day. You know, we want to focus on health, not when people are sick. We want to focus on living, not on life. We believe to live well is to be healthier. Next. So we're very excited that actually with digital, we are able to accompany our customers across their entire health journey. We built everything along our mobile app called My AIA. So starting with helping them to live well and then making sure they have the right protection and then help them to get well. As some of you heard the AI Vitality, in our app, we built functions to allow them to know where they are on the health and give some track and encourage them to do exercise, eat well and sleep more, for example, so that they gain some points and give them some exciting rewards. The rewards ranging from a lower insurance premium to discount in giant grocers and so forth. So when they're sick, they can file their claims electronically, and we will notify them along the way, whether we're still waiting information from hospital, whether your claims has been approved. So giving them a greater sense of control along the way. And if they want to see a doctor, they can use the telemedicine functions in our phone as well. And when they really get sick, we provide a case management to give them some advice to ensure that our customer have the right diagnosis, hence so that they can have the right treatment and they can recover well. Next. So in addition to that, we have also developed new digital solutions that offer digitally savvy customer, a simple bite-sized product that they can buy on their own, digitally end-to-end. They purchase directly, they receive contract to email, and they will service them via WhatsApp. We're already working with Shopee, and we'll be launching a product with Touch and Go Digital in the next quarter. So I think this is very exciting. I think the digitalization is already changing the way we live even before the pandemic, and I think it's just making it more permanent and making even a bigger shift. So we're very excited to be part of this journey and to be able to play a bigger and a more active role in helping our customers live a healthier, longer, and better life. So thank you very much.
Thank you very much, Ben. That was very insightful. Next, I would like to introduce the third panelist, Kanna, founder and CEO of ANDHealth. Kanna, a chartered accountant, spent his early days as a CFO for a company in Malaysia before embarking on his entrepreneurial journey. Kanna founded GCI, a global health tech company that won the prestigious Obamacare Meaningful Use Certification listing, the first non-US company to be listed for this. Kanna is now founder of ANDHealth, Malaysian-based global health tech company that's specializing in predictive, promotive, preventive, curative, rehabilitative, and palliative healthcare. Kanna, welcome to the panel.
Thank you, Gopi. Thank you for having me. Thank you for inviting me on this forum. Pleasure. It's very exciting that MDEC has chosen this as a topic of discussion, and I think it's very meaningful, it's very insightful, and it's very, very apt. That it's never not an apt moment, but I think what this COVID has, barging us with for the last 2 years, I think it's never a better time to talk about proper digital health to manage, not only for the pandemic situation, but a general situation where people live in a normal life. Please allow me to give you a little bit of background about ANDHealth. Yeah, ANDHealth was incorporated in 2003. Next slide, please. Now ANDHealth over the last, it's a company that was incorporated in Malaysia in 2003 as GCI MSC Sdn Bhd. Over the years, this is just one slide that talks about a little bit about what we have done over the 2 decades in different geographies in different countries. ANDHealth has made, through its digital initiatives, have made impactful changes in some 25 million lives in probably as many as, I'm talking about national digital initiatives in 4 countries across 7 national projects, right? Especially in the last 10 years. We are proud to say that we are the first entity when Obama announced his national digital program in 2008. We were the first one to actually secure the certification, first company to secure the certification outside the USA. So, and the 7th in the world, the other 6 being American companies. Today, ANDHealth, a rebranded company, has presence in 7 countries from Canada to Singapore. And we have successfully implemented more than 50 projects across 15 countries, from Trinidad and Tobago right up to India. Next slide, please. This is a little bit of our journey, right? Like I said, we started in 2003 with a company called GCI MSC Sdn Bhd. We secured our MSC status in 2004. Fortunately, during those years, 2003 to 2006, the governments in Middle East started to introduce a lot of programs that were intended to move their countries from a funded ecosystem. Malaysia is largely a funded ecosystem, right? Because government public health accounts for a significant majority aspects of healthcare delivery in the country. Middle East countries were like that in the early 2000. the plan, they had especially the GCC countries, the Qatar, Dubai, Jordan, Abu Dhabi, Kuwait, and Bahrain, Oman. They decided that they were going to move from a funded ecosystem to a reimbursement ecosystem. So they started introducing a lot of insurance initiatives with the intent of eventually getting to a state where every citizen in the country, expats or locals, will be covered with insurance. Now, the insurance can be a state insurance, can be a private insurance, or can be a a hybrid of both. So the intent was because healthcare funding through a tax system or government-funded ecosystem wasn't a sustainable one because it was continuously growing. So they needed to see how that can be transformed. So they started by introducing a lot of insurance company into bringing a lot of allowing private insurance companies to operate. And then slowly from 2003 to 2008, they started coming up with blueprints to enable full universal health coverage programs. The first of those countries that go universal health coverage was Abu Dhabi in 2008. Gradually, that became a practice that every country started to adopt, right? It moved from Abu Dhabi to Qatar to Dubai to Jordan, and some had a lot of success in doing that, enabling full insurance across the country. Some are still in the process. Like, for example, Saudi Arabia today is in that process. First of all, they're trying to corporatize the ecosystem and then gradually introduce mandatory insurance. So GCI was very fortunate at those years, especially implementing insurance and billing and EMR solutions at hospitals from 2003 to 2010 at individual hospitals throughout the region, right? Kurdistan, Lebanon, Jordan, Qatar, Saudi, Dubai, and almost entire Middle East. 2010 onwards, we were fortunate enough to participate, and we started winning national level projects. Okay, first one was Qatar, then went on to Dubai, then Abu Dhabi, and then Jordan. So these were the national level programs, national digitization of the entire public sector. Imagine doing MOH here in Malaysia. That's what we were doing for these countries, right? Different projects of primarily to do with universal health coverage, where they wanted to ensure that the billing, health insurance claims, reimbursement, adjudication was all digitized within one ecosystem, gateway where everybody was exchanging data, right? So we successfully completed 7 national programs from 2010 to 2017. 2017, we had an exit. American entity called IQVIA acquired one of our verticals, which managed the national insurance claims ecosystem throughout these countries. And we were part of IQVIA for the next 2 years, 18 and 19. 2020, we decided that we were going to start Avatar 2 of GCI, and that's when we rebranded GCI as ANDHealth. Right? Next slide, please. So that was a little bit about our journey from 2003 to 2020. So if you look back what we did in the 15 years, 2003 to 2017, we were largely focused in providing digital transformation for the public sector in these countries, right? It is to do with providing technology in the curative sector, right? That means if an individual walks into a healthcare facility, avail healthcare services, pays for it, or gets paid for it, this gets discharged or completes his outpatient encounter, he goes back. That ecosystem is what we were providing digital transformation for. Patient registration, appointments, typical EMR, HIS, ERP, revenue cycle technologies to enable the public sector provider facilities to have comprehensive digital ecosystem to manage their patients and their services. That was our focus. Now, coming back, into entrepreneurship, or getting back into our own footing, we decided that that is, yes, providing technology in the curative sector is an important element of providing digital transformation. But we said, okay, that's not the entire aspect of healthcare, right? So if you look at womb to tomb, and you want to bring the patient to the central focal, the individual, not the patient, the person to the focal, central focal, and say, let me look at what I can do for that person, for the government, for the payers. What are the technologies that will really be meaningful for us to look at the entire continuum of care? We started redefining and reimagining ourselves away from just purely a technology provider for the curative space. So we defined the scope of continuum care not only from a curative perspective. We started looking at it from a predictive perspective, preventive perspective, promotive, rehabilitative, as well as aged care and palliative care. So providing this, defining this ecosystem in the six areas of scope. When you look at continuum of care, we started looking at what are the technologies that we need to build to enable a predictive environment. What are the technologies that we need to look at for preventive, promotive, curative, rehabilitative, and aged ecosystem? We started building, this is 2020, mid-2020, right? So today we have, after a year, and leaning back on all of the experiences that we had before, how to build national technologies at scale and at population grade technologies, we started building huge platforms, right? The platforms are like your Uber and your Grab, but think of it from a healthcare perspective, right? We started building a platform for senior care. We started building platforms for pandemic preparedness. We started building platforms for organ transplants. Anything that is not just necessarily about a facility, but the entire ecosystem. We are also thinking of building something for the payer-provider collaboration, something that we did in the last 20 years, but trying to see what we can do better for that, so that payers and providers can collaborate better on a ecosystem where you don't have to you have to move away from the very fragmented ecosystem that we have today. So one of our platforms that we are it's going to be a flagship platform is our pandemic preparedness. I think in the coming months, ANDHealth will be launching that platforms in many countries, working with WHO, other CDCs in different countries, African Union, and even probably in our own within Malaysia. The idea of that platform, building that platform, is imagine that you have a weather forecast, right? You are able to forecast where is it going to rain, where is it going to, how many, what is the wind speed is going to be, what is which shores are going to be hit with a typhoon and other catastrophes, right? So imagine that in a infectious disease ecosystem. You're able to predict where the next dengue outbreak is going to be, where the next TB outbreak is going to be, any infectious disease, including Mr. COVID, of course. So it's a platform that is going to predict and, as much as possible, prevent any severe outbreaks with the knowledge of how to manage that specific diseases. We're very proud of that platform that we have built, and hopefully we will be able to.
Very impressive. Very impressive. Thank you. Very impressive, and all the best. Last but not least, our final panelist is Dr. Kuljit Singh, President of the Association of Private Hospitals Malaysia, has over 25 years of experience in medical practice, academia, and now a consultant ENT surgeon from Prince Court Medical Center. I must confess, there were a lot of titles there, and there were words I could not pronounce, so I consolidated that to ENT. Ladies and gentlemen, please welcome Dr. Kuljit Singh.
Thank you very much for the kind introduction. First and foremost, I must thank the organizers for giving me this opportunity to talk something about digital healthcare in the private hospitals in Malaysia. I must say that Malaysia has been one of the very first few countries in the world whereby we had hospitals in the public sector with electronic medical records. Hospital Selayang started their first hospital using electronic medical records 25 years ago. And we were one of the very few total hospital information system hospital in the region. And that subsequently led to many of the other hospitals in the public sector to embark on digitalization. And only much later, private hospitals started picking up the digitalization concept. So as we speak today, newer private hospitals do get themselves into total digitalization from the word go. But at the same time, if you want to look at electronic medical records, you need to have electronic medical records on a similar platform. You can't have electronic medical records working in silos. Private works differently. Individual private hospitals have their own medical records, which is electronically based, and then the government has their own. So in order to have a national electronic medical record system, in order to make the whole country digitalized in healthcare, you need to have one platform. Now, this is the challenge that most countries will have, and we also have the similar problem because there should be some sort of policy from the government to make sure that the platforms are actually the same. Now, the advantage of digitalization healthcare is, I will always say that there are many prongs when you have digitalized healthcare. One is on a regulatory perspective. It'll be easy to regulate private and also public hospitals. When I say regulation, it should not just be private hospitals, it should also be public hospitals, regulated to the level of the similar standards, similar care. And you can only do that if you have got all your medical records and your treatment outcomes, the methodology of treatment on a digitalized way. Otherwise, we will not know how outcomes are given to the patients, what kind of treatment modules, and how do we share. So that's one aspect of digitalization in healthcare. And of course, the other part for the private sector will be the financial link to the insurers and to the payers. Many countries have started using artificial intelligence in prediction of patients' bills. And that can only happen if you have a robust digitalization concept in your hospitals. So the insurers are already using their own digitalized methodology as we make claims, but there are no platforms for private hospitals to predict patients' costs, predict the type of bill that may have will be generated for an individual condition. So with a lot of case mix incorporated together with into a digitalization platform, hospitals will be able to use this to come with predictive values on financial healthcare. And end of the day, this would be the best way to actually calculate what are the kind of financial implications we have in healthcare costs. Today, private hospitals are always deemed to be expensive, deemed to be big, huge profit makers in the eyes of the government stakeholders and even patients. But you know, there is no way that sometimes we can prove to them that the healthcare is actually expensive. Healthcare has got an element of cost, which patients sometimes do not see. Government hospitals are fully subsidized, and there is a cost that you pay in a government hospital, which is paid by the government, but the patients do not see it. There is a substantial cost that is being paid. With digitalization, you'll be able to calculate exactly how much a particular treatment cost will actually cost. The important thing that we are looking at, what WHO has always been saying to us for the last 20, 30 years, healthcare for all. Now, today's scenario, healthcare for all will only be successful if everything is on a digitalized concept. If you cannot access to your medical records, you're not able to see a doctor on a timely fashion. You're not able to know what was your previous history when you change doctors, change healthcare providers, then you cannot achieve healthcare for all. It's going to be very difficult because, for example, I give you a very simple example that what we have in Malaysia. If you see a patient in a government hospital, A government doctor would do different tests, different investigation, but it becomes very difficult from then if the patient should shift to another hospital, let it be public or private, because the health records are not digitalized, and there is no way that, particularly in the private sector, that we can see those results, and most of the time we repeat everything all over again. So when we have digitalization platforms already available, we have to make it seamless. So it is very difficult sometimes to come to a special kind of platform. I'm not sure whether we use blockchain technology whereby we can amalgamate different systems into one so that we can read each other's system. I'm just talking, it could sound fiction at this point of time, but there are learned people in this platform who can actually tell us that if we have different kind of platforms, can we still speak to each other? The future may be there, whereby we can actually use this at least to get some basic information on our patients as they cross borders, as they cross hospitals. And digitalization is just not on a very silo manner. Just because my hospital has got everything on an IT base, and then we are proud of it being a digitalized hospital, it doesn't work that way, because that's just for the convenience of the systems within a particular establishment. It has to be across the board. So I think that is what we have to look at. We have to look at innovators. I can share my thoughts, my difficulties, but innovators out there should come up with something whereby we can find a solution for it. That's what I would think would be the best way forward.
Dr. Kulju, thank you very much. That's a great opening to what we want to discuss as a panel. We have with us an entrepreneur, a VC, an accelerator. We have someone from the private and public healthcare system, and we have someone from the insurance side as well. And with that, Dr. Kuldeep, I want to steal that last sentence. So you're talking about data sharing. You're talking about data that's currently not shared between private and public. Of course, it has to be anonymized, and we need to share and have a common platform. Is probably what you're getting to. Let's hear it from Bronwyn and see how Australia. I mean, you're based in Australia. How did you and your organization see this in Australia? Because I must say, your mics are on mute. I must say that it is a very heavily regulated sector in any country. Healthcare is probably the most expensive public spend. In any country, healthcare is the most difficult to penetrate. How is it in Australia?
I don't think at the cultural level, healthcare in Australia is any different to healthcare in every other nation. It's a highly risk-averse industry, and I think it should be. So when we think about digital therapeutics and the regulation of software as a medical device, lots of people said software can't kill people. But actually, if it gives somebody suffering from an acute or chronic condition misleading information, it can have a severe health outcome, right? So I think regulation is important. In terms of connectivity per se, I'm not aware of any country that's really nailed it or got it right. You know, there's over 15 pieces of federal legislation that relate to the privacy of personal health information in Australia, and that's before you start counting all the different state regulations and legislation that also impacts privacy. It's an incredibly opaque and difficult part of law to navigate at a legal level, but it's also it's quite complicated because when you talk to consumers, they say they want to own their data. And under Australian law, data doesn't attract a property right, so you can't technically own it. You can just be the controller of it or the custodian of it. And so when it comes to connecting healthcare, it's incredibly difficult. The My Health record has built, and this is not my area of expertise, but it's built a certain amount of plumbing so that lots of siloed parts of the healthcare system will transfer information kind of through a back-end system of pipes into your My Health record. So the point of My Health record is capturing that data from your private hospital, your public hospital, your GP, your pathology provider, your allied health provider, and at least providing a central repository that should reflect the sum total of your health data. it was implemented at a point in time. The Act only allows it to go back a certain period of time. It was opt-in for a long time. Many people didn't. Then it became opt-out. So it now covers, I think, over 90% of Australians. But I think about that kind of stuff as the infrastructure. It's like the roads that you need great roads for driverless autonomous cars to drive on. We need great connectivity for us to build new types of healthcare interventions. And so that piece, I think, is ongoing. We saw a massive acceleration in it through COVID with the addition of e-prescribing capabilities. So, not needing to get physical scripts, which is great. But, my daughter has to go to her paediatrician next week, and I'm still chasing my GP's office because my paediatrician hasn't received the referral by fax. That's how her referral goes, fax. And I actually said, do you want to print it out? Because it's probably just as fast for me to walk by my morning walk and take it with me. But that's, the scenario is we still have a whole bunch of legacy systems. So I think we've invested a lot in that My Health Record system and getting that plumbing in place. Now we have to work out how we can make that agile, responsive, how we can scale that. And then again, to points made by the panelists, how you can then link the private and the public healthcare systems. And also the whole thing about doing that is you have to do it without betraying the trust of the consumer. So if we think about healthcare system data, so when I access the healthcare system, in my life, I do it rarely. Most healthcare I've had is probably the birth of my 2 children. But, you access the healthcare system, that's some data. But if we think about all the other healthcare data that consumers generate, right? I have an Apple Watch. I'm sure they're popular in Malaysia as they are everywhere. We have sensors. We track our exercise. We, have these weird social networks about who rode their bike further or further or faster or higher. I think the big thing is how do we get patients and consumers to love the healthcare system so much they let us see the other data? Because that's the data that will tell us how we can make them healthier for longer.
That's interesting. This My Health data record, this platform that you're talking about, is it owned by the government?
Yeah, it's owned by the government. It's administered by the Australian Digital Health Agency, which is an agency of the Commonwealth Government. But in Australia, we have some complications because health is actually a state responsibility under the Constitution, but there's a lot of federal health funding. And then when you have things like pandemic, clearly there's a federal state. You can read the Australian news and see the tension between federal and state health priorities. So it's not quite straightforward, but it is a federal Commonwealth, all of Australia system run by the federal.
Got it. Kana, coming to you, Kana, you mentioned just now in your opening that you worked with 7 different countries in their public health side. What do you see the transformation that's going to take place in the healthcare between private and public?
Okay, now, fortunately, unfortunately, we work in an environment where on one side, while they were thinking of digitizing the nation and they moved towards that era over the last decade, especially in the GCC countries, one of the biggest mistakes they made is they made it a public initiative rather than a public and a private initiative. So they left the private on their own. They wanted to, the government had a control over the public sector, so they started digitizing.
When you say they, it's
the government, okay, like
any government.
Ministry of Health, Ministry of Defense, and but one of the things that they did is, like for example, Abu Dhabi, Dubai, and Qatar, they corporatized the ecosystem. They let the Ministry of Health, or in some cases they're called Ministry of Public Health, the public health ecosystem. The government became the regulator. Okay, they moved. They took the operator, which is the hospitals, away from the regulator structure. So one of the smartest thing they did, right? And then they corporatized the public health ecosystem. Now, corporatizing doesn't mean it's not free or whatever. It's remained free for a few years, and then they gradually moved that to a universal health insurance ecosystem, where it becomes now slowly it'll become a profit center, or rather a quasi-profit But the essence is, it's not that you're going to take away. See, in the US, the system is a little different because different from the UK or the Canada or Australia. Because in Canada, Australia, and UK, it's largely a social system, like an NHS system, and everything is covered, right? Almost everything is covered. In the US, it's the other way around. It's a lot of private and Medicare, Medicaid. That's very different. What the GCC wanted to do was take whatever ecosystem, build whatever blueprints, but they wanted to ensure everybody is covered, right? While they didn't want to burden the state with too much of taxes to actually fund that. At the same time, they were saying, let's look at people who can afford, let them. So it's a nice thought. But having, when one state decided to do that, then everybody followed based on that other person's experience, right? They tried to improvise, but they never quite got the full concept. Even Saudi Arabia, I think the Saudi Arabia initiative that's going on now, I think will be the most optimal one compared to every other initiative that has been happening since 2008. But my take is this: having seen what has happened in different countries, you take the lessons, right? I mean, what are the goods and the bad, and you try and see what you can do to improve that. And I sincerely feel that first and foremost, the regulators should be independent of the operators. And in Malaysian context, I mean, you said it's a free for all,
of course,
right? So I'm going to be, I'm going to be vocal about this. Ministry of Health should take the responsibility of becoming a regulator, or the government should decide that there should be a commissioner of health, which does not get involved in the business of running healthcare services. First thing, right? And then they look at the ecosystem from what should be an ideal ecosystem. Now, Bronwyn was just saying that she was not able to get a referral letter from a physician, from a family office to the hospital. That is, how easy it is to digitize that. It's a simple thing, and she's waiting for 2 days. And this is not Malaysia.
An opportunity there.
This is, the simplest of things. But who should sit and look into these problem statements, if you may, right? The problem statements are there with Ben. Ben has got a lot of issues. He's not able to get the codes that he wants to process. He wants to process the claim that is coming from KPJ, Pantai, any other clinics. Okay, he's getting a lot of claims, but what he's doing, the hospitals have got a different set of codes. He maintains a different set of codes. And then by the time it comes in, he has to map the codes, or he has to create, map me or code me kind of, before he does the adjudication, and then he processes. He's got a lot of issues. You ask Dr. Kuljit, he will say, oh my God, nobody's, insurance guys are not trusting me. Patients are, everybody's got a problem. So, and nobody's actually looking, frankly, nobody's actually looking at me as a patient. I have been going to the local hospital ecosystem for the last 50 years. My wife, my kids, my aunt, my grandfather, everybody has been going. But if I go to KPJ today, or I shouldn't be saying, okay, any private healthcare ecosystem, or public, if I go to HKL or Tawakal or Pantai, I have a set of records in every hospital for different reasons. My cough and cold in Tawakal, my, nephro records in HKL, my wife's stone, whatever is in different. Nobody knows. For the last 50 years, my records are everywhere. And when I am, when I'm trying to explain to the next care provider, he's going to ask me the entire, what Dr. Kuljit was saying, creating a single medical record. So like this, the situation is so fragmented, the ecosystem is so fragmented, there has to be a total rethinking of this before. Total revamp. A regulator should come in. The whole ecosystem should come in a call for collaboration platform. Ben should come in. Kuljit should come in. Liam should come in, the Bank Negara should come in, Ministry of everybody should come in and say, okay, these are our problem statements in the ecosystem. List them down. Okay, have there been a solution elsewhere in the world? And Bronwyn is right. No one country has made it perfect. But I'm telling you from the experiences of the 7 national programs, it got to where it got to because there was a CFC, call for collaboration. Everybody comes to the table, sits together, decides what exactly. Kuljit wants a standard code for his services. If Ben can agree on the same codes, you know how much effort is saved. Ben will sit and, he'll say, thank God, finally the ecosystem is agreeing to have one set of codes. And me, as a patient, as a customer in the ecosystem, if I walk to HKL, I walk to KPJ, I walk to Prince Court, everybody is having the same record, being able to serve me, knowing what my history is. That is another.
Very good. So thank you, Kanak. And Bronwyn and Kanak, you both brought up the same point, that is data sharing on a single platform. But Kanak, you brought up something very interesting. You need to have a regulator, right? You need to have a regulator in place, just like what we see in banks and in aviation.
Exactly.
Dr. Kuljit, what do you think? Do you agree that we need a regulator in place?
I think regulatory processes are important because if you don't have any regulatory process, then things are going to go all over.
But do you agree that there has to be a regulator, a commission?
Yes, I think that's very important. You need to have that because you see, even in the banking system, things are pretty regulated as much as I can look at it. Like today, there is CTOS. I don't need to go and get to show my financial records in order to buy a car right now. I just give my IC number, sign on a document to say that I consent. And then it is closely regulated by Bank Negara, and CTOS will be able to give information to the bank that I am eligible enough to buy a particular property, a particular car, and it is done seamlessly. And financial information, financial health is also something that I would say is private. There are privacy. So I think it's the same thing in healthcare. We have to reach to that level, but somebody has to regulate so that we don't get into a, we don't want to become fraudulous, and how fraud happens, especially in our part of the world.
Ben, you come from a heavily regulated industry already, insurance. What is your take and what you've just heard the panelists saying? It's about data sharing. It's about having all your data in one place, and a regulator in between to control everything. What do you think, Ben?
Yeah, thanks. Well, I think in terms of, the data is a new currency, right? So I think we all agree that. I think I believe the insurance industry, are open to to this, and I believe that Liam already have discussion, with APHM about forming some electronic data exchange. So there's some keenness on the insurance industry part to do this. But obviously, I think we're talking about people who got sick right here. I think the data, there's a broader picture, right, about helping people not get sick and what happened after they got sick. So clearly companies like ourselves, AIA, we want to start from the beginning, of keeping people healthy. And that's what our Vitality program do. We get people to do health assessment on the mentally, physically, nutrition, get a sense of all the assessment, and so that people can manage, their health accordingly. So they can take a photo of what they eat, so we can tell them how much calorie intakes they are taking. We're tracking our Vitality track how many hours they sleep every day, and because as we know, sleep and mental health, there's a correlation right there, inverse correlation, I should mean. And sometimes a lot of these things, funnily enough, behavioral science come into the picture. You got to make it fun. You got to make it reward. Many people who are on Vitality, they have to do like regular exercise. And the reward is you get 10 ringgit voucher that you can deduct from your Jaya grocer bill, or 10 ringgit added to the Touch and Go e-wallet. at the end of every week, and that's extremely powerful, you know. So I think data, you know, for us in AIA, we see this from end to end, you know, right from, you know, that how to get people live healthily daily, and then when they get sick, I think the electronic data exchange will be incredibly powerful because I think first, I think it will reduce the cost. You know, it's all about, sometimes it's about not a cake, it's how to make the cake bigger. And when the costs come down, everybody wins, right? Because, you know, just now, Bronwyn talked about facts. Sometimes you receive things in handwriting, you know, so incur enormous amount of costs for insurance company to process this. Every time we see somebody's handwriting, it's very hard to read. They say, oh, you could be a doctor. That's what. Can you imagine the kind of bills we have to process? So I think clearly that'll be a quick, that'll be a big win, and the data will also allow us not only to process it fast, but it allows us to give a greater sense of control to the customers. So a lot of time when somebody is sick, they're actually very nervous. Is my claim going to be approved? Will I get approved to admit in the hospital? Once I file a request, is it going to be approved? Why take so long? So now we're able to tell them, yes, we received your claim. We're waiting for this information from the hospital, and now it is approved. And if it's not approved, the reason why it's not approved. So that gives people a greater sense of control. Just like when you order a Grab food, they tell you exactly the kitchen is preparing your food, the driver is on the way. So that is what we want to give. And clearly, I think that will also improve the quality of care as well. You know, which make people healthy. So I think this is a good direction. Is it easy? I mean, I would say no, but I think companies are willing to work on this.
So Ben, I'd like to stay with you for a while because you brought up some interesting points. One is, with all this data and technology that's coming in, you think it's a win-win, and you believe that the cost will come down, which would mean that the insurance policy holders would have a cheaper premium to pay, maybe, because you have a healthier society, so less claims coming to you because you're now looking at how they eat, how they manage their wellness, and so on and so forth. So you have that part of it coming. With all this, and I'm going to open it up to the panel as well. With all this, we spoke about public health, we spoke about private health, we spoke about a regulator, we spoke about data being shared. With all this, we have disruptors, we have entrepreneurs coming in. We have entrepreneurs who can look at a problem, who can fix a problem using technology. And they're not even part of the hospital, they're not part of an insurance company. You have insurtech guys coming in, you have health tech entrepreneurs coming in. Ben, how do you see this disruption taking place in the insurance industry? And I'll go to all of you.
Yeah, well, I think for us, you know, we like to think we are a disruptor ourselves. Because
fast enough than the insurtech guys.
Well, it's never fast enough. That's why it's called disruption, right? So, I mean, clearly, you know, like I said, in the old days, until now, most part, insurance company mainly collect premium and pay claims, right? So how we want to disrupt the market is to get people to live healthy. I mean, I give myself a personal example. I was a smoker. I've been paying smoker rate for so many years, and then after even I become a non-smoker, I still stuck with a smoker rate on the policy I bought like 20 over years ago, right? So in the product that we offer, AI Vitality, you know, when somebody is a healthy, he paid 20% lower premium than a normal customers. So this is what we believe is a shared value concept, right? I mean, because health medical record is only one dimension of which you predict someone whether it's going to die or is going to get sick. But there are so many other dimensions, right? I mean, if people take responsibility to eat healthy, live healthy, exercise, that is as powerful a data as just the medical family history. You know, you can have the same medical history, family history, but you know, if someone taking that conscious effort, and this is a much better risk. So what we do is we believe in this shared value concept, you know, for our product today.
Great. Good. Bronwyn, coming to you. You are an investor. You are an entrepreneur. You see a lot of health tech companies. You see disruption. How do you see disruptors? And they're all over the world, very smart entrepreneurs who are possibly non-medical field, because they can think out of the box and they can see the problem better than you or me. And so, how do you see this disruption taking place? And how do you think entrepreneurs in health tech can play a role in this whole ecosystem you're trying to create, including the regulators? Sorry.
Yeah, so I'm probably also often called a disruptive influence myself. So I'll try not to be too disruptive here. So we've worked with over 450 entrepreneurs. And before I specialised in digital health, I did work across drug development and devices. I think the biggest differentiator for me is the diversity of the innovators and researchers that we see. So, you know, when we talk about commercialisation at a policy level, we tend to think about universities, research institutes, scientific organisations that spin out IP. In digital health, what we see is we see a lot more clinician innovators. We see carer innovators, patient innovators. We see some tech that comes through the traditional kind of science, academic-based research, but very little. But the overwhelming unanimous thing that they share is that they have to engage in the medical research framework. So they need to get clinical evidence or commercial evidence or evidence of health economics in a hospital setting or whatever it is in order to reach the market. So we've worked with some phenomenal innovators disrupting healthcare. One is top of mind. They just closed a $34 million round last night, announced in the press. They took the diagnosis of epilepsy, which under the reimbursement codes in Australia was 7 days in a hospital room being videoed. And they took all of that and turned it into a portable solution so that you still had to be videoed for 7 days, but you could do it at home. And that utilised an existing reimbursement code, and their original product utilised some existing hardware, whereas they now have proprietary hardware. And they've really transformed the accessibility of epilepsy diagnosis for patients. We have another company that does the gamification of adherence for medication adherence, another company that provides significant coaching and support to cancer patients and has quantifiable data about people returning to work after a cancer diagnosis. You know, so we have these really diverse things, but they are really disrupting healthcare. The biggest barrier, I think, is remarkably not regulation. So most companies that we deal with realise that in order to make a meaningful health claim, as in if you use us if you have type 2 diabetes and you use our program or app or sensor, you can reduce your HbA1c in a sustained way from 11 to 6, for example. That's a pretty specific targeted health claim about mitigating or managing or curing disease. So it falls under medical device regulation. Most companies we deal with go, I need to do clinical trials, I need to prove my claims, I need to get an approval. And they like that. They like it for a number of reasons. It gives them a competitive position that you can't just replicate overnight by building a new piece of tech. When you're selling into a healthcare market, it gives you the veracity of a third party saying this is what it is and it does what it says it does and it has got clinical evidence behind it. So if you're selling to an insurer from a reimbursement standpoint or you're selling to a doctor, they don't have the fear of prescribing something that's maybe not legit, you know. So in terms of the innovators and disruptors, we still see the biggest single challenge to going to market will be finding someone to pay for the technology. So straightforward consumer tech is relatively straightforward. Like if I'm using Uber, I'm paying Uber to get the service, right? So I'm the end user and I'm also the customer. The challenge in healthcare, at least in the markets we predominantly work in, and my experience is predominantly US, UK, and Australia, ANZ, is that the end consumer who ultimately benefits, so the patient and potentially the clinician, especially if it's a GP primary care solution, they rarely are the people that are willing to pay for it. So you have to build a product that has a compelling case for someone like Ben, or someone that is not the end user, whether it's government or a private hospital or a public hospital or an insurer. You have to come up with a compelling reason for them to pay for the end users to have access to this technology. And in Ben's case, it might be prevention of hospitalizations or prevention of severe exacerbations for people with chronic disease. And there's an economic analysis, but it's the only part of tech, really, or at least in my experience, I've done a bit of work outside of health. It's one of the biggest complications with digital health innovators is that the end user is unlikely to be your primary payer at scale. And how do you solve that business model problem? And so we do see diversity, and they've all got amazing tech, and most of them have some great clinical data. The tipping point between those that scale and those that don't, and in case of the epilepsy diagnostics company, they were in revenue very early because they had access to a billing code.
So, Bronwyn, do you think government should step in then for innovation?
I absolutely think that if we look globally, we're starting to see governments change the way they reimburse technology. And I think in Australia, the first piece was getting software as a medical device regulated, because I'm a taxpayer. I don't want my tax-paying dollars going to reimburse anyone that makes a wellness claim.
Yeah.
But you know, we've got a couple of models now. So the US has the CPT code model where they are reimbursing clinicians for their time to review data from remote patient management technology. So the clinician is incentivized financially to deploy the technology, review the data outside of standard consultation, and then go to the consultation informed by that remote data. And then if we look at the German example, we're seeing the reimbursement of prescription digital therapeutic apps. So they're actually reimbursing the subscription of the product analogous to a drug. So I think there's a few models evolving, but globally, absolutely, governments need to look at what medical interventions they are reimbursing, and they need to consider whether they're going to reimburse digital interventions.
Thank you. Kanna, coming to you. Disruption, entrepreneurship.
I've got a solution for Bronwyn.
Sorry?
I said I've got a solution for Bronwyn.
Yeah.
Oh, awesome. Send it over.
We can take that offline, and there you go. But kind of coming to your entrepreneurship disruption, by the looks of it and what I heard you introducing yourself, you managed to disrupt yourself, and out came Aincome. How do you see disruptors like you? And there are many, just in MDEC alone, there are 70 health tech practitioners having companies doing all kinds of things, right? How do you see the disruptors playing a role in this entire ecosystem you're playing? We are talking about. How do you see them? How do you see these disruptors, who are very, very smart, by the way, making a claim and improvising the healthcare system?
Right. Gopi, now the thing is, ANDHealth is trying to differentiate itself by saying we are not here to bring point solutions. I'm not here to bring the mobile payment. I'm not here to bring an app that gives you a womb-to-tomb record. We're not here to say, I want to create a gateway between the payer and provider so that they can do adjudication, reimbursement, claims, and all of that. We're not here to do point solutions, right? That's what we say, point solutions, right? We are here with the aim of creating an ecosystem. Now, when I say an ecosystem, it's a blueprint. It's a blueprint that says we should have a single vocabulary. We should have a single unique ID. We should standardize the code sets. We should have a single diagnosis standards. I'm saying that if you create this umbrella or this cloud of standardization, Ben can hook onto that. PCMC can hook onto that. The government can hook onto that. Everybody hooks onto one single unified ecosystem where data is standardized, exchange is standardized, language is standardized. You know how much of effective operational efficiency you will achieve by that. Now, that's what the public sector in the Middle East have achieved. Now, that's what when I say CFC, everybody should come onto the round table, create a call for collaboration environment, and state their problem statements, and then define an architecture, a blueprint that is going to slowly take into account. First of all, everybody on this forum is talking about digital health because we have to serve that individual person, whether he or she in the country, right? So put that person in the focus, look at the requirements, the interest of the payers, look at the interest of the regulators. And if you have this, the payer, provider, and the government working around that individual, each of their individual problem statement addressed and their interests taken care of, if this committee, this forum that I'm talking about is headed by commissioner, I think that will be, if you put that together, Gopi, if you can get the government to put that together, that's a first step in a very, very right direction, which will see us not repeating what Canada, US, UK, Singapore, all these people today are digitized, but are they meaningfully digitized? None of them are. None of them are. Because when you are saying you're meaningfully digitized, I should be able to go to any hospital in any part of any of these countries and be able to see the records of my records across all the previous. That's when it's properly meaningfully digitized. That is not there, right? Now, coming to your question of should the government invest or should the private invest, right? The government investing in digitalizing the ecosystem is not something that's going to be sustainable. It's difficult and it won't be innovative. It's not going to continuously evolve as the ecosystem evolves. It's not going to happen. It has to be driven by the private sector in collaboration with the government. How do you get the private sector? How do you get the individual to pay? Now, every one of us put an ATM card in the machine today. And if you're taking a Citibank card and trying to withdraw from Maybank, you're paying $1 or 50 cents or 2 ringgit, whatever, wherever you are. If you're overseas, you're paying 10 ringgit or 15 ringgit, right? Or $10. Do you actually feel the pinch? You don't really, or even if you feel the pinch, you grouch about it for about 6 months, a year. After that, you forget. You withdraw your 1,000 ringgit, $1 goes, you're just forgetting it, right? The consumer is paying. Now, way back in 2015, that's what INCA or GCI at that time did with Dell. We went to the Dubai government and we told the government, you don't pay a cent. We will digitize the entire ecosystem for you in preparation for you to go fully mandatory universal health insurance program. So they didn't pay a cent. The government did not pay a cent. It's like building a toll road. We built a toll road of infrastructure, technology, training, support, everything. And when they went mandatory insurance on 2017, we collected a small percentage of every claim paid by the insurers to the providers. Insurer will submit a claim, as a provider will submit a claim, insurer pays back. Insurance, there were like, I think in Abu Dhabi, there were 14 insurance companies. In Dubai, I think the equal number of insurance companies. They were paying the claim, but they were not feeling the pinch. Insurers had everything digitized. They had a single set of codes. They had real-time adjudication. They had pre-approvals digitized, no paperwork, no handwriting, no nothing. They had a full digital ecosystem and none of them had to pay it for 2 years. And then when they paid it, the insurers paid a small percentage. They didn't feel the pinch either. It was like 0.72 or 0.088% of the insurance claim. If you ask Ben today, if you can get me all what you have just said, and all I have to do is pay that zero, I'm sure he will say yes. I'm sure the Liam will agree. But when does this happen? This only happens when everybody comes and sits across the table and when they are talking to each other, right? That's when this discussion. So here I'm not even asking the government to pay. I'm not asking the individuals to pay. I'm asking you to put that 0. whatever percentage in the fee structure.
Yeah,
national...
it's like a pool. It's exactly how the toll works, as you said, rightfully, or how the aviation industry is charging $1 or ringgit or whatever.
Yeah, Asia has perfected that.
Yeah, so I was going to say that if we could do that, or even the telcos are also doing it. Dr. Kuljit, what's your take on what you've heard so far?
Okay, I kind of agree with everyone that have contributed, and I'm not going to repeat it in a different way. The meaning would be the same. I think end of the day is what I can see is, number one, healthcare costs are not going to come down. Now, it doesn't mean you have digitalization and healthcare costs is going to come down. No, that's not going to happen because the healthcare cost is a bigger aspect of it. Medication, equipment, fees, and the whole works of the cost of healthcare will always be on an incremental fashion. And we have seen that. But what now consumers are looking, including patients, would be value-based care. Now, digitalization will give them that value base. If the cost is going to be X amount and I'm going to get a value out of it, and digitalization is going to help, I think that is what I will not say it's destructive. It is going to be actually of an advantage. I'm going to pay X dollar and I'm going to get value out of it. I don't have to wait hours to see a doctor. I don't have to wait hours to wait for my medication. Whereas, let it be public or private. That's the value that digitalization is going to give to healthcare. So today, patients complain that it is even difficult to get a medical report, not record, a report from a doctor because there's a lot of paperwork. You write down, you wait 2 weeks, 3 weeks later, you get a report. You want to get a medication in the pharmacy, you wait. You go to any public hospital, including some private hospitals, sometimes you wait 2 to 3 hours just to get your medication. To get a refill of your medication, again, it will take time. So to me, I think it's not destructive. It's going to be advantageous to add on value to healthcare. And I agree with all my other learned speakers, what they have mentioned to you, but this is just my addition from what I'm trying.
So Dr. Kuljit, how is it different? Since we spoke about aviation just now, and this is coming to my mind, how is it different? That aviation was heavily regulated, very expensive, so difficult to buy a plane, to maintain the seats, the food, the comfort. It is so expensive, and yet companies like Virgin and AirAsia were able to come in and disrupt the model, and then from something that is so luxurious, everybody could fly. So can we come into a model where everybody has healthcare, everybody has insurance, sort of a model, because we have this sort of ecosystem, this sort of a commission or a regulator coming in between?
I think aviation, as an example, may not be actually apple to apple when you compare to healthcare. Healthcare is actually basically from the very beginning, it is always priced as low as possible to make it as affordable. Even though in private, I've been in this private sector for some time, I've seen actually hospitals try to bring the bill down as low as they can, and still it looks a lot. In the aviation, I think there were a lot of frills. There were a lot of wastages. There was a lot of costs which we couldn't see. I'm sure most of us here had air tickets which had triplet carbonized tickets, which comes like a booklet.
Tells you our age.
Itself, apparently, sorry?
Tells you our age.
Yeah, that shows our age. That triplet booklet itself, what I was told is it was costing 30 to 40 ringgit per ticket. And then we have gone away from all that. So I think there were a lot of costs that was put into the aviation feeling of your entire flight experience. Had a lot of, I would say, inflated kind of values or financial values put into. So they managed to bring that up. But in healthcare, it's not going to work out that way because everything is actually expensive. And even I buy a medical, any kind of medical equipment you buy in Malaysia is bought from overseas. Health, there is a financial transaction, and the prices just go up and up. So I think to make a difference with the aviation and healthcare may not be the best example.
Okay, so we have 10 minutes. We have 10 minutes more. There are a couple of questions coming in on data privacy. But because there's so many questions on data privacy, can I rephrase the whole question and probably ask the panel to answer this? Should the data be anonymized to protect data privacy? Anybody? Yep, please, Bronwyn.
Yeah. Sorry, go on, man.
Up to you. But look, yeah, sure, data should be anonymised, but unfortunately, every time the Australian government has released an anonymised data set for public research purposes, some very smart academics at various institutions have managed to prove that it's pretty straightforward for them to re-identify the data. So I think anonymisation is a fantastic principle, but it rarely works in practice because as soon as you build something to anonymise data, somebody else will build something smarter which can de-anonymise it. So, I mean, I think anonymisation has a role to play, but I mean, I think increasingly consumers don't believe in it.
So what's your answer to that?
I personally believe that finding more efficient ways to secure consent is and look, there may be a cultural difference here, but certainly in Australia and the UK, all patients believe that where their data is being used, especially by the private sector for health and medical research, that they should have the right to consent on a case-by-case basis. So I would prefer to see increased sophistication around consent. And in order to build that trust I talked about, that then means that we can access the data that happens beyond the healthcare system. Because if we just say, we have the right to use your data, we'll anonymise it, then why would they give you any more? I think you have to treat it with a certain amount of respect. People feel intensely personal and an intense sense of personal ownership over their health data, more so than their financial data or other data. Their health data is intensely personal and they feel a very strong connection to it. And I don't think ignoring that connection gets us very far in a long-term scenario. But that's a personal view.
Kana, you were going to say something?
I agree, totally agree. And you know, it's difficult. There are just before you can think of finding a way to secure the data or enable privacy around the data. Somebody else is cooking up a hacking ecosystem somewhere to, you know, it's not going to be. You should take appropriate measure to make it secure, make it you know, whatever compliant, HIPAA compliant or whatever, and ensure that the privacy is maintained. But the consent management is very, very important. I think at every stage, when you throw a consent request at a patient, I mean, it's that takes away a lot of the problem about you know. And if you educate the public enough that to say, okay, this is what is going to happen to your data, but we will alert you with appropriate consent alerts at every stage of the encounter.
Tighten that process, tighten the governance,
exactly.
tighten transparency.
You cannot escape from you know, this.
Yep.
You know, even as we speak, some health systems somewhere in the world today is being compromised.
So it should have a system like how the online banking is working, very, very tight, right? Dr. Kuljit, what's your take?
I think we have to probably start somewhere. And sometimes there's always fear about privacy. You know, many years ago, people of my father's age, they were so skeptical of using an ATM card. Going to an ATM machine and then getting money out of the ATM, they would rather still go to a cashier, and they found that getting money from a cashier is more secure. The ATM machine probably will leak information to the whole world, apparently, but not realizing the cashier is probably will be able to leak the information of your financial account to the rest of the world. So it was just better off getting used to it. And I think we also, as human beings, I mean, the moment you do something new, and the trust, I think the word is trust here. You just make people trust that this system works. So I think it's just a matter of time. The younger guys can adapt to this earlier, and I think they have more threshold to trust, probably, because they kind of put everything on Instagram, put everything on there, you know. So I believe, I'm not sure, I'm in between. I'm stuck between the guys who are senior to me and junior to me, so I really cannot come up with the right paradigm of thinking whether it's going to be feasible. But I look at my son, he seems to be like okay with anything, you know, in that sense. But yet they will question, are you sure this is secure? But hello, why are you talking to me about security when you put everything that you do on Insta story? So you are not worried about that side, and then you're questioning me whether this is secure or not. So, you know, I think you will reach somewhere.
True. Ben, you have a take on that?
I think data privacy is obviously very important, and I think the consent is absolutely key. It's nothing like accepting all cookies, you know, when you visit a website. I mean, this is a serious because health and financial data are very personal. And...
Good. So we have exactly 4 minutes left. I want to give a chance to all of you, all four of you panelists. I'll start with Ben. Ben, what is your prediction for the next 12 months? Because we want to meet again at the next MTM, and we want to talk and see how far we have come. Ben, what's your prediction on how this whole health tech will take shape?
Well, maybe you know, I mean, I like to see more moving into electronic data. You know, clearly, you know, our part, we're doing that so that we can apply all this data analytics, machine AI and machine learning, into making this whole cost of providing health insurance far more efficient. So I see that a lot of disruption should continue to be into the wellness space as well, not just the, when people get sick, but as well as people before they get sick. I mean, look at all this Fitbit, and Google buying to Fitbit. I mean, that's where the trend, so I think we should take a look at the healthcare from the end to end. And today, I think the other thing that we try to do more is a lot of time when people get sick, they get so nervous, where to get help, is to be able to offering them to get help, so that they get the right diagnosis and the right treatment. So I see that this will gain more popularity, as time goes. Yeah.
Thank you, Ben. Dr. Kuljit, how do you see? Maybe your prediction, can government, private and public start working together even a lot more closer?
I think the COVID has slowly brought us together. Now, COVID did not do everything wrong. I think there are a lot of good things that COVID has done. We couldn't sit on one table and work together, but because of COVID forced us to have this public-private partnership. To date, we have decanted 2,000 over patients from the public sector to the private, which would have never happened if there was no COVID. So I think we are definitely moving very fast. I just heard that YBKJ is the Minister of Health.
Oh, good.
So I can see a lot of new things coming out of his dynamic way of how he handled the vaccine. So I can see, I mean, as I told you at the beginning part of this talk, I think by the time we end this talk, we'll have a minister, and we have a minister now. And I'm happy it's him.
Good prediction.
Good prediction, right? So, yes, 1 year from now, with the new minister on board, with a young minister with new thoughts, I think digitalization will take a little bit of a better leap than what we have right now.
Thank you. Kana, what's your prediction?
COVID, this is essentially another year of COVID. Whether it's pandemic or endemic, it's going to be that COVID year for the next, before I see you next time on the same forum, right? So I see a lot of point solutions become, the digital disruption is going to happen at the point solutions. Your teleconsultation, your augmented virtual care, your smart glasses, that kind of stuff, whatever is happening, that is going to keep happening. That's all going to be at the point solutions, right? I can't see a major digital health program discussion happening in this year, but it should. I'll be very happy if such a thing is at least initiated, because it's not going to be a one-year thing. Something like in Malaysia, if you want to do a proper digital transformation, it will take at least 5 years, full end-to-end. That is assuming that tomorrow everybody sits on the table, right? But what I see happening is a lot of digitization happening to see what we can do to be prepared for the next pandemic. That is something that's going to happen, okay? Because this pandemic has cost lives, livelihoods, and severe impact on the global economy. So where I'm sitting now, I'm seeing Germany, the US, UN, every global donor organization, everybody throwing money into universities, into research centers to see why are we in a reactive mode when something like this happens? So they want to be prepared. So I see a lot of money. Universities like John Hopkins and Stanford and Duke are getting 150, 600 million just to see what we can do to prevent something like this from ever happening. There you will see a lot of this digital disruption.
Thank you, Kana. Bronwyn, we started with you, we'll end with you.
So I'm going to I agree with everything that my esteemed panelists have said, but I'm going to end with that. I am hoping to see the collision of health and border control. So the disruptive health technology is changing how we control our borders. So I want to see digital health disruption empower our lives to enable us to live with COVID. So secure digital vaccination passports that open up boundaries, the use of internet-connected rapid point-of-care testing for COVID for people returning from travel and who may be in home quarantine. you know, the utilization of technology that exists to give us back our lives as we move on to a period of living with COVID. It's now endemic in the global population. I want to see health disrupt border control and give us our lives back. I want to be able to be there with you guys next year. I want to see my husband's family in Britain. I want to be able to show my children the world. And I think the only way we do that is by embracing technology and the understanding of technology and health as it pertains to opening up the world post-COVID.
Thank you so much, Bronwyn. Panelists, thank you so much. I have learned a lot. I learned that we need to be, as far as digital health tech ecosystem, we need to be able to be connected. We need to stay connected. We need all the other players coming in. We need to be with the border control. We need to be with insurance. We need the banks. We need a regulator. And at least in Malaysia, now we have a new minister. So with that, panelists, thank you very much. Stay safe. Good luck. Take care.
Thank you. Bye. Thank you.
Thank you, Gopi, and to our esteemed panel members for that insightful discussion on the future of digital health, reshaping so many aspects in our lives and livelihoods. So we will now be moving forward to our next session of the day. We will begin very shortly. Do click join session and also complete the survey for us to continuously serve you better. See you in a bit.